Hello everyone, myself Dr. Prateek Garg. So today we are going to discuss about tracheostomy. So what is tracheostomy? It consists of word trachea and stomy. So what do you mean by tracheostomy? It means to make a hole into the trachea. Okay, that is known as tracheostomy. This is a diagram showing the human trachea. As you can see, this is my cricoid cartilage, which is a part of the larynx. It is a complete ring. Below that, the tracheal rings start. Trachea start at the lower part of the cricoid cartilage and ends at the level of the T4 vertebra. Okay. In a human body, or we can say human adult, male or female, the number of tracheal rings are around 16 to 20. And then trachea it bifurcates into primary bronchus and secondary bronchus. So trachea consists of 16 to 20 rings, and the first two rings they have increased chance of necrosis. The reason being they are somewhere related to the subglottis area, that is at the lower border of the cricoid cartilage. So this is the narrowest part of the airway. We can say the larynx, that is a subglottic area. So at the junction of cricoid and the tracheal first ring, there is the part is very narrow and it has high chance of necrosis. Most common site of the tracheostomy is between second and third ring. See, in a human body, when we can do the tracheostomy, it starts from the first ring at the up to the level of the fifth ring. So we do the tracheostomy in between first to fifth ring, and the most common site is second and third ring. If we do the tracheostomy at the first ring, that is at the starting point of the tracheal rings, then it will called a high tracheostomy. If we do the tracheostomy at the second ring or third ring or fourth, so second to fourth, then it is the mid tracheostomy, which is the most commonly performed tracheostomy. If we incise or make a hole in the trachea at the level of fifth ring or lower than that, okay, so that will known as low tracheostomy. There are certain indications for high, mid and low. We will discuss it. Now, the most common physiological complication in the tracheostomy is the apnea. What we may apnea, it occurs due to the CO2 washout. I'll tell you one incident. During my residency, once my senior got a call to change the tracheostomy. The patient was on ventilator. It was a neurological comatose patient. So patient was already tracheostomized since last 15 to 20 days around. So when my senior went to change the tracheostomy and he just removed the old tracheostomy and inserted the new tracheostomy tube, patient suddenly collapsed. The reason there was no any breach in the trachea or any breach in the esophagus, no pleural injury was there, or no other known complication was there. So the most common reason find out because of the death of the patient was sudden CO2 washout, and sudden CO2 washout that leads to metabolic alkalosis, metabolic acidosis, and suddenly respiratory gasping. And what is the most common complication of tracheostomy? If I don't talk about the physiological, the most common complication is the bleeding. Obviously, while doing the tracheostomy, we encounter firstly the anterior jugular vein. And then what we encounter is the thyroid vessels, thyroid veins. That is the inferior thyroid vein mostly. Because over the trachea, the thyroid lobes lie. The mid part of the thyroid gland, that is the median lobe, it rests over the trachea, and both the other parts of the thyroid cartilage, gland, they are over the both sides of the trachea. So thyroid vessels are in close proximity to the trachea, so they also have the chance to get injured. So most common complication, hemorrhage. Most common cause is venous as compared to arterial, and the vessels involved are thyroid vessels and anterior jugular vessels. Now, the most common incision what we prefer, see there are two conditions, either elective, if the patient is continue on the endotracheal tube intubated, that means in the ICU patient was there, it was already intubated, so we don't have to hurry up. So in that case, the type of incision we prefer is a horizontal incision. We put a horizontal incision along the neck crease. What is the advantage? Advantage is the cosmetic, because scar will be very less or minimum, or there will be no scar because it may merge with the neck crease. But what is the disadvantage? The time taken of the surgery will be more, okay? And in any sort of emergency, what kind of incision we prefer? That is a vertical incision, because if I put the vertical incision and we will retract both the skin and the subcutaneous tissue, so the time taken for the surgery will be very fast. But the only disadvantage is the long scar, which will cosmetically will be not so appealing. Okay, so Horizontal is for the elective and vertical incision is for the emergency. These both points are important for the examination point. Actually, all these points, they have one or two times they have been asked in the exam. So what are the point I mentioned here? Now, what is the position of the tracheostomy? That is a rose position. What do you mean by rose position? We just ask the patient to lay supine over the table, over the OT table, and we will put a shoulder back beneath the shoulder so that my neck will get extended. So the neck tissue will get pop up. So it will be easier to dissect, obviously. So the position used is rose position. Rose position again is also being used in like tonsillectomy, adenoidectomy surgery, etc. But we have to take care of this position in any traumatic patient, because if there is some spinal injury at the cervical or something else, so we have to firstly look out for that, because if you extend the neck and suppose there is some vertebra fracture or something, so there will be chances of injury to the spinal cord or the nerves. Now, there are three types of tracheostomy. I have already told you: high, mid and low. The site I told you: high is for the first tracheal rings, mid for the second, third, or third, fourth, and the low for the fifth. Now, what are the indication of high tracheostomy? The most common indication is CA larynx. CA larynx. It has been asked 2 times in the exam, because in carcinoma of the larynx, we will remove only the carcinomatous part and we will try to preserve as much respiratory tract as much we can preserve. So in that case, we will prefer the high tracheostomy. What is the side effect? Again, the laryngeal stenosis. Again, the examination point. It has been asked 2 times. What is the cause of the laryngeal stenosis in high tracheostomy? I told you, the first tracheal ring and the subglottic area are the narrowest part. So any edema or any inflammation will lead to the stenosis. Now, the mid tracheostomy, all other indications like any sort of COPD, emphysema, or any trauma, maxillofacial trauma, some long-term intubated patients, every other indication that comes under the mid tracheostomy, where we put incision over the second, third, or the third, fourth ring. Now, we'll talk about the low tracheostomy. That means we will put incision over the fifth ring or below than that. So why it is being done? The indication is laryngeal stenosis. Suppose the laryngeal stenosis, so along with the laryngeal stenosis, mostly the first 2 rings of the trachea are also involved, and they will also be stenosed. If they are not stenosed, still the inflammation process will go on there. So in that case, what we prefer is the laryngeal stenosis. What are the other indications? Suppose there is a neck tumor mass, big mass. Suppose a thyroid tumor is there. So in that case, the upper part of the trachea will be obscured by the tumor. So in that case also we can prefer the low tracheostomy. So what are the disadvantages? There will be more chances of injury to the great vessels. We all know that in the midline or suprasternal notch, the arch of aorta, the brachiocephalic trunk will be there, and there will be thoracic vein, and etc. Okay. Now this is a diagram showing the tracheostomy sites. So now, tracheostomy, ideally it should be changed every second to third day. Again, examination point, it has been asked, so I'll star mark it. Okay, so every second or third day it should be changed. If suppose my old tracheostomy tube get blocked, so again I'll just remove it, clean it, and I can reuse it. But still it should be changed. So what is the what is the advantage of tracheostomy? It decreases dead space by 30 to 50%. Again, important. How it decreases? It just bypasses the above tract, starting from the lips, oral cavity, or we can say the nostril, till the level of the larynx, or till the level of the tracheostomy site. It just bypasses that tract. In that way, it decreases the dead space by 30 to 50%. What are the indications? The most common indications, like what we see in the routine OPD life, is like the patient with the emphysema, patient with the COPD, or the chronic lung disease like pneumococcosis, sarcoidosis, or any other disease. If suppose atelectasis of the lungs is there, then also the tracheostomy is very important. Laryngeal carcinoma, again we have discussed, in laryngeal carcinoma we prefer the high tracheostomy. If the patient is on prolonged ventilation, and again this is the most common indication in the child, if the baby is on the prolonged ventilation, or suppose the patient is intubated for the long, so we will prefer doing tracheostomy, because prolonged endotracheal intubation will invite the infections like the gram-positive cocci or the pseudomonas and other infections. So through that endotracheal tube, they can go into the lungs and will cause pneumonia or septicemia or other indications. indication. Okay, now more other indication is like to remove the secretions from the bronchi. And suppose in a road traffic accident, is suppose the upper part mandibular injury is there, maxillary injury is there, or my tongue got edematous. So what will happen? The upper airway system get obscured. In that case also we will prefer doing the tracheostomy. And suppose if there is bilateral vocal cord palsy, if the both vocal cords come in close proximity to each other because of the paralysis, that happens because of the bilateral recurrent laryngeal nerve injury. So that will cause a bilateral vocal cord palsy. In that case also, we will do the tracheostomy, and then further we can treat for the vocal cords, or we can make the new airway passage in the larynx by doing the surgery. There are two types of tracheostomy tube most commonly preferred. The first one is a metallic tracheostomy tube, which is also known as Chevalier Jackson tube. Okay, so it consists of three parts. One is the obsolete, then inner tube and outer tube. So it's a metallic tube known as Chevalier Jackson tube. Nowadays, the preferred tracheostomy tube is Portex plus cuffed tracheostomy tube. Cuff means there is a balloon over the lower part which we can insert the air into that balloon, so that will fix the trachea and just prevent the secretions from the upper part of the body, that is the oral cavity or oral pharynx, to trickle down into the lungs. So in that way the cuff tube is helpful. So Portex tube, that is the most common.